What's going on, everybody? Welcome back to another episode of the Core Consult RX podcast. Cole and I are joined by some guests today. It's been a couple episodes since we've had guests.
Yeah, it's just me and you.
Yes.
It gets lonely.
It does. Extremely lonely. I should turn the volume off on my my laptop so that when I get an email, it doesn't come up on the recording. So today, we have in the studio with us, we have two of my fourth year students, one of which was Cole's intern for a long time too. So finishing up almost at the finish line. We got Lauren and Boone with us today. Or is Boone your real name?
Ooh,
is it really Butte?
Yeah. Butte. Well, most people
Boone
call
goes
me,
by an alias. And so like when I get an email from him, I'm like, who the heck is this guy? And then I realize it's Boone. So
yeah, I like to keep people guessing and keep people surprised.
No, it's good. It's very surprising. Lauren, what's up?
Hi.
Lauren has listened to pretty much every one of our episodes.
She might be the only one.
The only one. I know.
Every single one of them.
If there is another number one fan out there, let us know.
Yeah.
I'm interested.
Yeah.
To see what kind of crazy person listens to all our episodes.
It was really to make sure I passed the rotation.
Yeah, that was a good call for sure. That's one of the first questions I ask upon entering my rotation.
Mike has failed so many students.
Like
it really was the only way you'd pass.
Case in point, it's not looking good for
100%.
Boone so far because I don't know how many episodes he's watched, but it's probably not enough. So
checked off that osteoarthritis one earlier today.
Okay, well that's
one out of 133.
Well, there you go, Boone.
I got some time left in rotation.
2 solid weeks, better catch up. Yeah, so we're happy to have you guys with us today. So I'll tell you what, either one of y'all start first. Whoever wants to go first. Give me a little bit of background as far as, pharmacy school, what it's been like for you, and then what plans afterwards.
All right. Well, usually it's ladies first, but I feel like Lauren's going to have a good bit to say, so I'm just going to try to squeak in first. So, yes, my name is Boone, and my plans as of now, I am awaiting match day on Friday, and apparently it's been some pretty stiff competition this year, and to all of our listeners out there, good luck to you at this point, and probably by the time you listen to this, it'll probably be congratulations or, we're going to have to figure out something else to do, but kind of
what do they call it? Is it the scramble or is it the second round for whatever it's called?
Yeah, we'll see how that goes this year. But we'll
nice. Keep your fingers crossed.
Yeah, shoot for the stars and potentially be looking for some alternatives just in case. But
you'll do good. Fine. You'll get it. Yeah, you'll get it.
Lauren, what's your story for looking like after graduation?
So like you mentioned, I was Cole's intern for a good little while. And I have worked in a community setting all throughout pharmacy school, and I'm hoping that that'll be the plan after I graduate.
Nice.
So anything, so the whole push towards doing residency and stuff like that just wasn't enough to push you over the edge, huh? To let go of that job?
Nope.
They tried.
All about that customer service.
Well, Mike has really advocated for, not needing a residency.
Whoa. Don't say that.
No, I don't want to say not needing one, but it not being the only way.
No, it's not the only way. It's just if you follow Mike's way, prepare for a lot of sleepless nights and 18-hour days of
my
studying.
way sucks. Don't do my way. My way will take a long time, and you'll have to use all your PTO to go hang out with other pharmacists and learn. And it's just a nightmare.
But you're right. We are. I guess we're examples of that. You don't have to follow the conventional route to get somewhere else. If you decide that you don't like community, you like community for your whole life, and that's fantastic. If that's what you want to do.
I think where people get my message twisted is the whole, and I'm not saying you, Lauren, but where I've seen in the past is where people take my message as far as like, dude, residency sounds awful. You got to work all these hours. And like, this would be easier if I just start working, making money, and then I'll just become a clinical pharmacist later. And I'm like, yes, that would be sweet. However, that's not what I did. And I probably would have had a lot more time had I just done the residency program and gone that route instead of spending the first 3.5 years of my life outside of school.
But consider all of the progress you've made for the future of pharmacy.
Boone, that's a bit of a leap. But you're so uplifting today. You're already giving the people like messages, hey, even if it doesn't work out for you, not to jinx you or anything, but it's going to be fine. Very uplifting. It's great. Good to have you here, Boone.
Inspirational episode.
Oh my gosh, I feel better already. Wow. Really brings something to the table, Boone. I like it. But no, that's cool. What are we talking about today?
Cellulitis, right?
Ish, yeah.
Not the first I heard of it, but the first I saw it in real life, I was on a 4th-year rotation, and I had a patient who had a lot of medications. She was really overweight. I think she was immobile. And I was supposed to go in there and kind of do a med rec for her, whatever, before the doctor came in. And I was talking to her, but she was just asking me, showing me her ankles, and was asking me about this redness and what appeared to kind of be a rash, but, redness and swelling. And I was looking through a med list, and me being the astute pharmacy student, I saw carbamazepine on there. And I was like, oh my gosh, this lady's got Stevens-Johnson syndrome.
Done.
And then, so, the doctor's like, what's going on? I was like, well, this, and this got these drugs. And she's got Stevens-Johnson syndrome.
No.
He said, what? And he looked down, and he's like, I think this is just a cellulitis. I was like, okay.
It's most likely that, but I'm glad you passed the test I just gave you.
I was like, but in my mind, it was so funny because I thought I was right. I was like, I got this.
You're
like,
done.
it's Stevens-Johnson's. And, in my age, I've realized that he knew what he was doing.
Dude,
But,
I had a similar moment like that where I was on the stroke team, rounding with the stroke team, and one of the neurology, I think it was the chief resident, was talking about this patient who their potassium went really high, and like I can't remember what the result was. And something they were mentioning the potassium, and I was like, well, maybe I saw the patient had Bactrim at some point, like in the last month. I was like, maybe like I knew Bactrim can like increase your potassium levels, and maybe that's what like did it. And blah, blah. He's like, potassium induced or Bactrim causing induced hyperkalemia, whatever he's called, leading to whatever seizures or whatever the patient had. He's like, yeah. He's like, dude, I love this guy. He's hilarious. And he thought I was joking. I was like, yeah, man, I am funny. That's exactly what I was going for. And I'll shut up now.
Nice try.
At least it worked out. He was cool.
Good. At least he wasn't being like sarcastic.
No, he was
really
genuinely thought I was joking. Yeah, he was dead serious. He's like, this guy's hilarious. I was like, that's me. I'm always trying to lighten the team up. Because, strokes, those are, gotta have some comedy around here. Oh, man, that's crazy. But that was a cool rotation nonetheless.
So yeah, the what I thought was Stevens-Johnson syndrome was erythema, or the redness and the swelling that comes along with the cellulitis, which is basically one of the types of skin and soft tissue infections. So you have maybe a puncture of some sort, or it could be microscopic, and you get a colonization of bacteria. You have an infection. You have redness and swelling, and we'll talk about the two main types, which are non-purulent and purulent. I always struggle with that purulent word. But Purulent. Yeah. Purulent. We'll go with that.
And as far as like guidelines and things, like the Infectious Disease Society of America put out guidelines back in like 2014, and there's been some like Medscape articles and things like that have summarized different things. But the guidelines really hasn't changed too much in the recent years. So it can be a little confusing because they put out all of their skin and soft tissue infection guidelines at the same time. So, as far as like lumping all those different types of infections kind of together. So when it gets to the purulent versus non-purulent skin and soft tissue infections, it can be a little confusing, I feel like, as far as the breakdown.
Yeah. If you're looking at an individual infection, it's not bad. It's just when you take the 12 or whatever it is that they lump together, it gets a little overwhelming.
So just to kind of give some background information, when it comes to non-purulent skin and soft tissue infections, specifically we think of like cellulitis type of situation. There's also a couple other like classifications, if you will, Erysipelas is basically like the superficial version, so a little bit like closer to the skin surface, if you will, version of cellulitis, so it's not quite as deep, and you have like this sharply demarcated kind of region around the wound itself that kind of shows where it starts and stops, so to speak. Typically speaking, the bacteria that's usually causing that infection is going to be like a group A strep. So like a strep pyogenes, and it can be others as well. So like there's some like group G and some group B infections. And there actually can be some cases where it's a methicillin susceptible Staph aureus as well. Those are a lot more rare, but it can happen. And then once you get more like into the subcutaneous, so a little bit deeper, then the erysipelas, and as far as the extent of the infection, that's when you get into more like cellulitis, so to speak. And so Same bacteria though. It's going to be typically caused by that strep A or group A streptococcus. And they've done studies and like looked at different like, pathogens and things like that. And that seems to be kind of like the main bacteria that's causing those two from a statistical standpoint. So when we start looking through like some of the empiric data, you'll see that it's basically going to be different options that cover that strep species with some coverage of Staph aureus, just to sprinkle it on there. But it's mostly the strep A coverage that we're looking for.
Yeah, and we'll see that most of the time, especially in mild cases with this non-purulent, it's kind of a clinical diagnosis, like similar to what the doctor did. He looked at it, he felt it, and you know when you see it. Looks like cellulitis. We're going to treat it with this. You don't necessarily have to do a culture and sensitivity unless they're high risk or unless they have some possibly purulent or other issues that we'll talk about.
And then when you get into like severe cases of cellulitis, so a little bit deeper into the tissue, potentially even into the almost to the muscle region, you can even get like some necrotizing cellulitis where the skin actually is rapidly breaking down. Necrotizing fasciitis as well is a severe infection that, especially when it first starts, it can very much mimic and be confused with just plain cellulitis. And so we'll talk about some treatment options and things like that as well for when you get into a situation like that. But necrotizing fasciitis is usually when you're getting into more like the deeper soft tissues as well as the muscle area and things like that, and overlaying subcutaneous fat on top of that. So, and it's a very rapid breakdown and can be very detrimental to the person's well-being. But when we go through the treatment options, we'll kind of see how they differ depending on the severity and all that.
Yep. So yeah, non-purulent, it can be mild, moderate, severe. You have the erythema, the pain, the swelling, the redness. It'll be warm to the touch. And then you kind of take all that and add in a little more when you get into purulent cellulitis. So it may have something more visual, like a furuncle, which would be like a boil.
My favorite word ever.
I know.
Furuncle.
It's my favorite kind of uncle. Next to carbuncle. So there's also carbuncle, which is basically multiple neighboring furuncles that form a single inflamed area. Whereas a boil, a furuncle, like you would imagine, is an infection that begins in a hair follicle, but eventually becomes an abscess. It can drain spontaneously. So it's characteristic of, if you ever played sports, specifically football, we tended to have some MRSA go around, and I never really knew it was very serious. But it was not unusual for me to see one of these white, pustular type of boils on somebody's elbow or something, just because you're wearing the same practice jersey or pads or whatever for whoever knows how long without washing them. And then you had that guy who literally didn't wash it the whole season. And if somebody gets MRSA and it starts going around on all the stuff, people are going to get MRSA. And I never got treated for it, but I definitely had it at one point. So, or at least I had a boil of some sort that was colonized with something. I don't know. But yeah, it's characteristic of that. So usually the boils are caused by MRSA, MRSA, and the carbuncles as well. And it's purulent, and it can be literally just drained, and that might be okay if it's a mild case, but you may also need treatment if it's a more moderate to severe case.
Yeah. And then if it's like you'll see cellulitis lumped in with like purulent cellulitis, sometimes they'll refer to it as, and that's basically where it's a cellulitis that's associated with the original like abscess or furuncle, carbuncle area, and that's kind of like a purulent cellulitis case where it's still draining and all that, and so that the drainage and incision on the part needs to be part of the treatment as well as the antibiotics. But yeah, like Cole said, MRSA is really what we're worried about causing that particular disease state.
Yeah, pharmacists aren't very procedural, and so I guess I knew that you could do incision and drainage and treat abscesses and things when I was in school, but hearing my wife talk about it more when she would see it and have to do that, and especially when it was in a very uncomfortable painful place, makes me glad I was a pharmacist.
Yeah.
Not something I'd want to do.
It's definitely, especially when you start dealing with like the really bad infections with like the rotting, necrosis skin and stuff. It's like, oh, goodness.
I mean, we've got, Dr. Pimple Popper over here, so I'm sure that you would, that would be something you'd enjoy, right?
First of all, how dare you smear her name by pretending she's me?
She would be
very offended by that. But all right, so looking at treatment options, and there's a nice like table in the guidelines that kind of lay everything out in a very simple form. But from just a general empiric kind of scenario, if we're starting with mild non-purulent infection, so remember again, we're trying to treat strep pyogenes, we're going to be giving oral antibiotics. And as far as differentiating between mild and moderate, we're thinking mild is going to be the actual skin infection, but it's not going to have any kind of systemic effects. So it'll just be something that can be treated with oral antibiotics in the outpatient setting. Patient's good to go. And so you can use just plain penicillin, like VK, oral penicillin. Now, if you want to give the dose less frequently, so instead of 4 times a day dosing, do 3 times a day dosing, you can do amoxicillin as well. Either of those, or you can use cephalexin. And then if you really want to make sure that we're having like some Staph aureus, so even methicillin susceptible Staph aureus coverage as well, if there's a concern about that, then dicloxacillin is an option as well, and then clindamycin. Those are the 4 that the guidelines list. Obviously, you can use others, but for the most part, you're only treating these for like 5 days in some cases, sometimes maybe up to 10, but it depends on the patient's progression and cure rate and all that stuff. But for a lot of times, these 5 days is enough to kind of get rid of the infection. And so it's something that it wouldn't really be realistic to get cultures and then kind of de-escalate. If you start with dicloxacillin, found out for sure it's strep, and then want to switch to amoxicillin, it's just not going to be likely to do that. So sometimes you'll start with like something like dicloxacillin. So even though it's a little bit more broad spectrum, you're still covering just in case you get that rare case of Staph aureus in the case of a mild non-purulent. But yeah, if you notice, all of these are very narrow spectrum, with the exception maybe of Clinda. And so you're getting that because of that narrow spectrum, you're not adding to the resistance problem that was so prevalent nowadays.
Yep. So if you're considering moving from, if you consider them mild, not mild, but moving up to moderate, like Mike said, you're going to have more systemic symptoms. So you might see fever, chills, overall fatigue, certain specific exam findings like pain, like excessive pain that's disproportionate to what you would expect from this examination. A circumferential cellulitis, or something they call lymphogenetic spread, so like red lines streaking away from the area of infection that might be signs of a more severe infection moving up to the moderate stage, even close to the severe stage. So you might see a little more of the systemic stuff before it's like emergent and severe. But if it's moderate non-purulent, then instead of oral, you'd want IV. So the options for IV are mainly the beta-lactams and clindamycin. So penicillin, just like the oral, but IV here. Ceftriaxone, cefazolin, and clindamycin.
And then nafcillin too. Did you say that?
I did not.
That one's also listed as, and because that's going to give you your Staph aureus coverage as well. So yeah, basically the IV versions. And then again, you're treating these for such a short period of time that, maybe if the person needs to be converted to PO, then it would be basically just whatever covers similar. So nafcillin could be switched to dicloxacillin if you were going to send the person home. But it's usually going to be 5 days or so treatment option, and hopefully it'll be taken care of. But same concept. All of these are treating that strep pyogenes primarily, with some Staph aureus coverage if you need that thrown in there. But what is considered to be like a severe non-purulent infection? That's where things can get a little bit different, especially if it turns into some kind of like a necrotizing infection. But it could be just as simple as a failed oral antibiotics in the patients. Maybe they start oral antibiotics and the condition gets worse. That's going to be more indicative of a more severe infection. Patients who are immunocompromised, obviously, it's going to put them at risk. Patients experience like hypotension, any kind of like end organ dysfunction. If they meet SIRS criteria, so remember it's a systemic inflammatory response syndrome, or SIRS, is going to be a patient has to meet two or more of the following criteria, where their temperature is above 38 degrees Celsius, pulse is above 90 beats per minute, respiratory rate is greater than 24, white blood cell count is either less than 4,000 or greater than 12,000. And if they meet two or more of those 4 options, then that's considered search criteria, and then going to be considered a severe infection. Now, if there's a presence of like skin sloughing or you start seeing any kind of signs of necrotizing infection, then that's when you definitely want to get the surgery team involved so they can kind of assess first before you even give antibiotics what we need to treat for.
If I was in bed and the doctor was treating me in the hospital and he said, skin sloughing, and wrote that in his chart, I'd be really concerned.
Yeah.
Yeah, that's when you want to...
It's not ideal.
It's not
Doesn't
ideal.
sound great.
No. So that's when you'd want to consult surgical.
Yeah. So in the surgical consultation, because they may need to go in and do the debridement and make sure that they're cleaning out the area and then starting antibiotics right there. But do kind of get like an emergency surgical consult just to see if you need to go that route. Some other things that you can use, obviously, imaging, so CT, some MRI possibly, for if you do need to assess and see if there's any kind of necrotizing fasciitis there. Some labs to kind of, that would push you in the direction of that would be like an elevated white blood cell count, possibly more than like 14,000, an elevated BUN level, so around 15 milligrams per millimeter, or milliliter, I said milliliter or greater, or if you're...
That's a long
it's
BUN.
an extremely long BUN. Or if the patient has a reduced sodium level, so like less than 135, would raise some concerns that it could be necrotizing.
Yeah.
And then needs to be definitely have a surgical procedure before just jumping on antibiotics.
Yeah. So you'd want to get blood cultures, of course, in this case, CBC with diff because you're looking for left shift, and then get creatinine bicarb, creatinine phosphokinase, and C-reactive protein. Those would be some recommended labs to draw to be able to see all that.
And the issue is, especially in the case of like a necrotizing infection, just like we said, like when it's early on, like cellulitis and then something that's going to develop into necrotizing fasciitis could be very similar, and they could look very similar early on in the infection. So if we do meet some of the criteria for severe infection, we don't know if it's just something as simple as in a severe cellulitis case where it's most likely still going to be the group A strep, or if in the case of necrotizing fasciitis, that can a lot of times be caused by like polymicrobial pathogens. So anaerobic and aerobic microbes kind of together. It could be, depending on what caused the infection, it could be MRSA, it could be different types of things like Vibrio or Aeromonas, which we can talk about in a second. But depending on what kind of happened that led the person, to being in this situation to begin with, and that can also play a factor as well. So really, you're going to want culture and sensitivity reports back to kind of see where you need to go. But empiric therapy, after you've gotten the surgical consultation, empiric therapy is going to be something like Vanc plus Piptazo, so Zosyn. So that's going to be your coverage of your MRSA, as well as the Piptazo is going to cover all of your, extended spectrum bugs and like your gram-negative bugs, things like that. So you're kind of getting a wide range of coverage. Some alternatives, like if you couldn't use Vanc for whatever reason, instead of that you could use linezolid, would be a good change. You could use one of the carbapenem instead of the Piptazo if you wanted to cover that way. There's also a recommendation where they use vancomycin plus, instead of Piptazo, they'll use ceftriaxone plus metronidazole, so like a 3-drug combo. That's also an option as well. But something along those lines, as long as you're covering around the same range of Vanc and Piptazo, that's going to be your empiric therapy.
Yep, and I think you mentioned some of the instances, but even if you're going back to mild, even if you're considered mild, instances where you might want to go ahead and get a culture and sensitivity or get blood cultures might be depending on the area that the infection is presenting. So if it's on the face, especially around the eyes, you might want to get it just in case, because if you need to escalate or de-escalate, you want to know that. If the patient may have come in contact with potentially contaminated water, so we'll talk about that a little bit, then even if it seems mild, that might be an instance. And I think Mike mentioned immunodeficiencies, so chemo if they have cancer or other immunodeficiencies, and then animal bites. You want to culture animal bites.
Always culture the animal bites.
Yes, I have a friend who what is it? I can't remember. He's gotten bit by a lot of dogs.
A lot of dogs?
Like a lot of dogs, yeah.
He's not very good at eluding them, huh?
Well, he's a salesman, going to like the.
Did he go door to door in 2021? Wow.
Yeah. Well,
sorry. I'm sure he's a great guy, but
I can only imagine that male people probably have been treated for lots of dog bites as well.
Do male people go door to door now?
I guess a lot of places. Yeah. Well, I mean, they don't walk necessarily, but they're getting out.
They got that cool truck.
They got the truck.
I think it's awesome.
You'd like to drive the
sure.
like you're in the
Why
UK
not?
or something?
Sure.
On the opposite side?
Leave the door open too, because I don't know rules. Be like a convertible, only different.
Yeah.
Yeah. I'm not wearing the shorts though.
Slightly different. I don't know. I think they're pretty snazzy looking shorts.
Maybe. What do you guys think?
I mean, I was like a man in uniform, right?
Oh, jeez. Basically, yeah.
Might be a backup plan for us.
Maybe. It's a good thought.
I knew somebody who was a male woman, and she said it was very stressful.
Can't even imagine. Yeah. Extremely. So, all right. So let's say culture and sensitivity reports come back. There's our rabbit trail for the evening. If we get culture and sensitivity reports back and we have like a documented necrotizing group A strep that's causing it, or certain types of clostridial infections, we can get away with, instead of using the Venk and the Piptaza, we could de-escalate and just use PenG plus clindamycin. And the clindamycin's on board there to kind of help with the the toxins being released by the strep. And so that's kind of helping to double coverage in that case, if you have for sure documentation that it's that. Now, if the patient does have some sort of a necrotizing infection that's you culture, and especially if they've been in salt water, like I saw this happen to a guy who was diving in somewhere off by one of our beaches or something, and was diving, and something happened, like a rock fell on him or something and gashed him open, and he ended up getting really bad, like necrotizing fasciitis from it, and then they found out, they cultured and found out it was Vibrio. So in that case, the guidelines recommend giving doxycycline plus ceftazidime. And I always think when I think of Vibrio species, I do kind of doxy kind of pops in my head. That's the way I kind of always remembered that. And then if the patient was in fresh or like brackish water, which is where fresh and salt water kind of meet in the middle, which we have a lot of areas around where we live that are like that. Fresh or brackish exposure, we're more worried about things like Erysipelas causing it. And in that case, we're going to do doxy plus ciprofloxacin, would be the two recommended drugs of choice. Erysipelas, I always, whenever I think of that particular like microbe, I saw a patient that had been bit by a diamondback rattlesnake when I was in school, and he was in I think it's the Sticku, and they had given him Crofob and stuff like that to treat the actual venom, but then his skin was sloughing off because of the venom, and so they put leeches on his hand to kind of like keep the tissues perfused with blood, keep the blood flow coming to that area and stuff, and they had to prophylactically treat with Cipro when they had the leeches applied because of the Erysipelas in the leech's mouth, which makes sense because they're freshwater leeches.
Very interesting.
So they were using that as
because I remember seeing the leeches in the inpatient pharmacy
in the pickle jar.
In the pickle jar, I guess.
You think they're going to be like this elaborate container? No, they're just like a dill pickle jar. Yeah, they just emptied out and like, there's still these stupid bugs in here.
I mean, I think my memory, it's more like a styrofoam cooler looking thing, but yeah, they're just sitting there like on ice or in water or something like that.
Yeah, it's just like, oh, those are leeches, huh?
I guess I never thought that you'd have to prophylactically treat because they can cause harm.
I don't know if it still is, but I remember when I was on rotation there that Cipro was on
Orset?
But it was like what do they call that? Where it's like restricted use because of all the like gram-negative resistance they were getting against Cipro. Yeah. So it was unrestricted use. So you had to get like an infectious disease consult, and it had to be certain scenarios. And one of them was leech therapy. And that was because of the killing off the Erysipelas in the leech's mouth.
Very interesting.
Do you imagine you like don't do that and you give someone leeches to fix their necrotizing skin, and then all of a sudden you just introduce a new type of bacteria that causes the same thing? Crap.
More sloughing.
Oops. Yeah, that's uh-oh.
That is an uh-oh. Well, somebody had to do it first,
Had to. And you're like, I wonder why that happened. Oh, shoot, they have bacteria in the mouth. We probably should have checked that first. I don't know. That'd be interesting to see how that actually played out.
Yeah.
All right, what do we miss? Anything on non-purulent?
I think we're good.
Boone, we
think we're
covered
good.
okay?
I took good
Seems
notes.
good to me.
We hit everything in your notes?
Yep, you hit everything in the notes.
All right.
Crushed it.
Cool. So we already talked about the presentation of the Purulent. And if it's a mild case, it's pretty easy. You're just going to incise and drain. So incision and drainage of the abscess. And you don't necessarily have to treat them with antibiotics, which was so weird to me when I was first, again, hearing my wife just describe their treatment. I'm like, y'all didn't put them on anything? They're like, no, we just cut it and let it drain, and they're good to go. And it's because it gets rid of the majority of the colonization, and your body kind of handles the rest. So you don't have to give them antibiotics.
One thing, this is just, I don't know why it's just popped in my head, but since it can be caused by like a boil and things like that, one thing, if you guys are ever like in like a retail setting or something, sometimes your older patients will come in. Lauren, tell me if this ever happened. Patient comes in with a boil and they say that they want some kind of drawing salve. Have you seen anybody ask for that?
I've never had that happen.
I've definitely had that asked
Yeah.
for. Yeah. And I truthfully didn't really know what they were talking about.
So there's
All right,
like
now I don't feel so bad.
there's like a old product called like, I think it's Ictamol.
That sounds familiar.
And it's basically like what it is. It's like this drawing like salve that kind of like brings the boil like to a head, so to speak, and then helps it to pop, which I guess would be the same concept as incision and drainage, only with witchcraft instead of real procedures. And but every time I hear like a drawing salve, like people be like, "What the heck is this person talking to?" And I worked with this one older pharmacist one time that I remember telling me that when I was in school. So I always knew it was like, take them all. I know what you're looking for, my guy. Let's go look.
Which, did you have it?
There was some kind of I think it actually said drawing salve.
I wonder what it does. I'm interested to know how it works. I mean,
I don't know.
It's like a magnet for pus. Pus magnet?
That's
Yes.
gross.
Yeah. Think of it as more of a black hole, like a pus black hole. It just pulls it right in.
Pulls it right out.
Yeah. Neil deGrasse Tyson taught me that. But yeah, it's I don't know. That just popped in my head. So I figured that's a fun fact in case any of you guys ever get asked that question by one of your older patients.
I can only imagine it would make pimple popping better if you just draw it all to a head and,
Maybe. I like the sound effect.
Yeah.
Now-
We don't have your sound effects anymore, so.
No.
Oh, yeah.
Too many buttons to push. I can barely keep up with just
I know.
moving the mouse.
That's what we need somebody in here pushing your
know.
money signs and toilet sounds for.
We had a whole we had a whole like soundboard at one point that
I think
we
we
were
had some
really
Arnold
proud of.
Schwarzenegger on there too.
It's okay. We have Boone to be the soundboard now.
Yeah.
Yeah. Thank you, Boone.
Thank you, Boone. It's very
Appreciate it, man.
extremely helpful.
You know, if you'd listened to all the episodes, you would know about the soundboard.
It was
That'd be for another time.
it was there for a significant amount of time, at least
It was a good little minute.
20 episodes or so.
Was it?
Not that you used it in all of those, but throughout the course of
It
maybe
was sitting
20.
there. Yeah.
Yeah, it was there, and you probably popped it, every once in a while. It was just dead half the time.
You were super excited about it at first.
I was, because I'm always excited about trying some new thing. And then after I do, I was like, that's lame. I'll try something different. I don't know how many times I've ripped everything off the walls in here and restarted.
Yep.
Cole was like, why? We just put all that up. I was like, I hate it. Let's rip it down.
I got to hear about it at work.
Yeah.
Cole thinks I'm a lunatic. It's okay. I come in here every day and go, what can I change? How can we make this better? Anyways, all right. So mild infection, we're not going to treat with anything. Moderate purulent infection. Still thinking Staph aureus and most likely MRSA. So we're going to, in this case, moderate, we're still going to treat with oral antibiotics. And so for empiric therapy, besides doing the incision and drainage, we're also going to add on an empiric antibiotic that's going to cover for MRSA. So doxy or sulfamethoxazole trimethoprim Bactrim. Now, if cultures come back and it shows that it's methicillin susceptible, then you could consider de-escalating. Again, the odds of actually having enough time to do all this may not make it worth it.
Especially because they're probably ambulatory anyway.
Yeah.
And, it's not like they're in the hospital and you can just step it down because you just stop whatever they had and step it down to something else or whatever.
Yeah. So if it was the case that if you just were your favorite thing on earth is antimicrobial stewardship and you just felt compelled, you get cultures back, realize it's methicillin susceptible, then you could always switch to dicloxacillin or like cephalexin or something of the two options listed from the guidelines.
So yeah, that's moderate. So getting into severe. So when do you consider something a severe purulent infection? So if they have failed what we've already tried to do. So we did incision and drainage, we added on the antibiotics and they failed that can be severe. If they're an immunocompromised patient, that can be severe. Or similarly to non-purulent, if they meet SIRS criteria, so 2 or more of what Mike had talked about before. So if they meet SIRS criteria, that can be severe as well. You're still thinking Staph aureus and probably MRSA, so you want to cover with IV antibiotics. So we're still doing the incision and drainage, and then we're adding on IV antibiotics, and we want MRSA coverage. So options similar to before, we have vancomycin, linezolid, daptomycin, and then there's also ceftaroline and telavancin would be options that you could use there. If it comes back and it shows that it's MSSA, if it's susceptible, you can de-escalate to nafcillin, cefazolin, or clindamycin would be the other options.
Yep. And like I said, there's a chart that's available in the guidelines. They basically list out, what you can use, especially in the case of non-purulent. They have a very nice little breakdown. And then if you have like a defined, culture back, it kind of walks through like the different, whether it's Vibrio or Aeromonas or if it's polymicrobial. That's the other thing that we didn't mention is the Empiric Therapy, where you do the Vanc plus Piptazo for non-purulent severe infections. If it does come back as being polymicrobial, you can continue that regimen and just call it good. So if you do get back a culture that shows aerobic and anaerobic kind of together, you can go ahead and just keep them on that Vanc Piptazo, and that'll take care of it.
Yep.
But yeah, what else, guys? We miss anything?
Correct us. What else we got?
I have a question.
Yep.
So, like in severe, are we treating like for a certain number of days? Are we doing it based on cultures?
It's based on patient presentation still.
Okay, so like clinical.
The guidelines will still say like 5 to 10 days usually is what it'll take. But it just basically says some patients, even in the severe case, will be 5 days and you'll have it cleared up. But it says basically just going off of
clinical presentation.
Yeah.
Okay.
And one thing I do want to mention too, and this is the guidelines state this as well, clindamycin we've mentioned several times as an option, but that needs to be used in cases where resistance is like confirmed to be less than 10 to 15% at that institution. So looking at your antibiogram and making sure that most likely your resistance rates are down for clindamycin if you're going to use that one. Mm-hmm. You don't see too much clinda used nowadays, but figured we'd throw it in there since it's still in the guidelines. Cool.
Super duper.
Nice.
Anything else we need to cover, Cole?
That's all I got, man.
Cool. Well, thank you guys so much for listening. Definitely, if you have any questions or comments or concerns or anything, definitely send us an email, which will be in the show notes, or if you want to send us a direct message on Instagram or Facebook or whatever cool platform you want to be on. If you want to text directly, you can do that as well. Just send a text to 415-943-6116. And also, thank you guys so much for those of you signing up for our Patreon. It's been awesome to see how that's been growing, and that definitely helps us out a lot and helps us to continue to make the show better and stuff like that. So greatly appreciate the support there. And if you have any ideas for how we can make that better, we're toying with a few different ideas as far as like practice questions / tests or different test prep things. Like we haven't figured out what we're going to do yet, but we're in the works of coming up with some other ideas for Patreon, but we'll keep you posted on that. But yeah, thank you guys so much for the support. If you do like the podcast, make sure you subscribe, leave comments, whatever you want to do. It helps us out as well when it comes to showing that our podcast is making moves. I definitely appreciate that. And we'll see you next time. Have a good night.